Today we're talking do's, don'ts, and basics of providing care to patients experiencing intimate partner violence with Joseph Polich, MSW, LCSWA, JD. All right, and what we're going to do is we've got Joe's bio, but we're going to find out our top 5. Joe began work in the field of IPV sexual violence as a volunteer for his local DV agency in high school. This was inspired by several disclosures by his brave friends. Joe's partner, Jamie, gave birth to their first child, Eno, in November. He is named for the river at which Jamie told Joe she just wanted to be friends in 2013, and B, where she agreed to marry him in 2018. I need to zoom out here because we need Joe's we need Joe's smile in there for that.
That's a really nice memory.
Well, congratulations and congratulations on the new one.
Yeah, I'm
that's
tired.
Awesome. I'll bet.
Tired napping.
Joe is a postdoctoral research fellow at UNC Center for Poverty Work and Opportunity, working under Jean Nickel from 2012 to 2014. Joe interned at NPR in 2002 and house sat for Linda Wertheimer. This is where he first ate goat cheese. He didn't like it. You still don't like goat cheese?
Still don't.
Okay. We have a wicked pizza recipe with white pizza with peppers and goat cheese.
Pretty plain Jane when it comes to cheese.
And Joe convinced his wife, Jamie, to watch a single college basketball game with him, the 2016 national championship game versus Villanova. And was that first and last?
First and last, yeah. We lost the last second. And she was like, it's a great game. That was a great game. Never again.
There you go. Well, Joe, thank you so much for being here today. This is great. I mentioned poll everywhere. The first question, IPV is an abbreviation for intimate partner violence. True or false? We try to make this kind of a softball, this first one. There are disclosures. Thankfully, I don't have to read those anymore. You've seen them. You've read them. And here we go with poll everywhere. So
that's great. Well, so far, it looks like that was a softball.
Okay. Okay.
And that's good. Language changes all the time. And what people used to call intimate partner violence, they might have called domestic violence or way back, maybe even just domestic issues as a way to sort of gloss over the huge public health issue that intimate partner violence is.
Joe, excuse me for 1 minute.
Yeah.
I just realized that we've got something running in the background, which is going to make that loud ding every time an email comes in. And I think we want to avoid that. So let me just shut that down and we can spare our audience that. And let me come back to here. And
there we go.
All right, there you go. Sorry about that.
That's all right. I'm just glad I'm not getting the hook already. So as language evolves, we think more and more about the words that we use, and that's a great process. And I think the reason why we say intimate partner violence now is that it's because the power and control comes from the relationship between the people and not where they live. So it's not just domestic partners who live together, whether they're in a romantic relationship or not. It's anyone or any pair of people that have a close personal relationship. That could be family members. It could be romantic partners. And it could be, very close friends who also live together, if we're going to be really technical. So it's good to focus on the fact that it's any pair of people who have an intimate relationship, which serves as sort of the power that allows people to sort of abuse and control and manipulate others. That's just my information. I might leave you with a lot of questions. This is a huge topic for 1 hour. I love hearing from people, and if you have any feedback or questions, please send me an email or reach me on the phone. I want to start really with an idea that might seem obvious, but bears some thinking. And I wanted to start with this quote. Few people who are hit once by someone they love respond in the way they might to a singular physical assault by a stranger. The reason why I wanted to start with that is this. It's easy to fall into a trap of believing you can relate to someone else's experience because you yourself might have had a similar experience, or you have an experience where you think maybe that's a corollary. And I think it's important to remember that if someone has experienced the awful event of being struck or abused by a romantic partner, no one knows how that person would react, even the victim themselves. And so if we are treating patients and in our everyday lives, being around people who are experiencing this kind of violence, we have to kind of throw out our preconceived notions about what we think that person would act and look like. And we certainly can't use the situation of simply being hit by a stranger or a non-intimate partner to believe that that is like a similar situation, because the entire undergirding of intimate partner violence is that you have this special relationship. I'd like to start with a case study, and hopefully at the end we can sort of revisit this with some of the things that we've learned along the way. And I'll just read it really quickly. I know you can read, but I just want to kind of warm myself up to it as well. Gloria is in her mid-30s. She has one child who is 9 years old and is currently pregnant. She and her husband separated after the birth of their 9-year-old, but recently got re-engaged prior to her becoming pregnant. Gloria has a history of being the victim of childhood sexual abuse, and she carries a diagnosis of PTSD. Gloria is a stay-at-home mom and primarily is responsible for upkeeping the house and planning activities for their son. Gloria's main source of support is her faith community. Her husband allows her to use the family car to attend services and church groups throughout the week. Gloria goes to the ER when she has repeated panic attacks. Due to suicidal ideation, she is involuntarily committed and spends 1 week getting inpatient psychiatric treatment. When speaking to Beacon, the program I work for, she describes her husband as emotionally abusive, and when asked to clarify, she says that he puts her down. Gloria adds that her husband says she's a bad mom for needing to be in the hospital, and Gloria shares that she has few friends. Gloria feels trapped in her relationship and regrets remarrying her husband, and when given the option of using domestic violence shelters or emergency shelters, she believes she needs to stay at home because of her pregnancy and resulting need for stable shelter for her new kid on the way. So I'd like to keep this person in mind as we're sort of tackling some of the issues, because this presents a very challenging situation for a social worker, nurse, or any sort of healthcare provider who meets someone like Gloria. So what I'd like to start with, another question: what is your biggest challenge in talking about intimate partner violence with your patients? So I guess this is a short answer one.
Right. And so we'll just, it'll take just a minute for those to come through.
That's
so
great.
Bear with us, and we will be looking for those and hopefully see, here we go.
Great.
So, all right. So those should pop up. There we go.
Okay.
And we'll start feeding more as our
That's great. This poll ever is really cool.
It is, absolutely.
There's lots of challenges. It's a very difficult thing to do, especially because I think while we are trying to be careful with our language and be sensitive to people's needs, it can almost be, we can get overly cautious and decide, you know what, that's a touchy subject, so I'll avoid it altogether. Fear of invasion of privacy is sort of summing up that dynamic. We just don't know how to ask. We don't know if we should ask, right? Boundaries, right? If I am treating you for something not related to your intimate partner violence, is it my job? And how do I make it my job? Lack of trust, another answer that popped up, can cut both ways. It could be that the person has a lack of trust in the medical system or people in general. And if we sort of dive into the topic in a way that scares the patient, that might ruin the trust between patient and healthcare provider. And so it's a really difficult thing to do. And hopefully by the end of this hour, you'll feel a little safer approaching the topic and maybe knowing a couple of things to do. Here's some of the ones that I was kind of guessing would be some of the answers: not knowing what to say, not knowing if you can help, not knowing the resources available, difficulty getting private or safe access to the patient without their partner around, because a lot of times it's the partner who's bringing folks in to receive healthcare, and fear of damaging our relationship with patients, because what we would want to avoid is that patient never coming to see us again. That's a very scary result, especially if you're worried about their safety. I want to kind of briefly go through, what the Beacon program is, and it's really helpful for people who are in the UNC Health System, outlying clinics, or even hospitals that aren't at the main medical center in Chapel Hill. So it's a group of social workers, and we tackle topics like intimate partner violence, but also human trafficking, elder abuse, and sexual violence as well. We're around during the week and on call over the weekends. And I think the value that we bring to the healthcare system is that we have time. So sometimes if you have a 15-minute time slot or a 30-minute time slot, and someone mentions a concerning dynamic at home, maybe in the last 5 minutes, maybe your office doesn't have time. We have time. We're sitting around waiting, and we can spend an hour and a half talking to someone and spending a lot of time on this sensitive issue. So listed here are all the options for contacting us. This is just a list of what we do. We do some brief counseling. We provide resources. We document things in the patient's chart really briefly so that other people are aware of the situation. We help people create safety plans, and we'll talk about that in a moment. We report to law enforcement when we have to or when the patient wants us to. And we assist case managers in planning for discharge. All right, so here's going to be sort of the main topic for probably the next 20 minutes or so, the basics and red flags. This is going to be a lot of information, but I want you to relax and know that even if you take home 10% of this, you're going to be able to be a more comforting and more confident healthcare provider. I took the beginning of the North Carolina Coalition Against Domestic Violence's value statement to sort of point out that physical violence is sort of what we typically think of, or what we first think of or imagine when we hear domestic violence or intimate partner violence. It's a lot more than that. So I'll read the statement. We believe that domestic violence is a pattern of domination in which perpetrators intentionally choose to cause fear, injury, and/or pain in order to gain and maintain power and control over their partners. In addition to physical violence, abuse can be sexual, emotional, economic, and can include stalking. So the real things to remember here are the words power and control. That's the lens through which we're going to be doing much of our work when we're helping people who are experiencing intimate partner violence. One of the sort of keystone bits of information that we share with people experiencing intimate partner violence or people who are helping those who are experiencing it is called the power and control wheel. It's been around for a long time, and there are lots of adaptations of it. But what I want to talk about is sort of the symbology behind it. It is a wheel. There are spokes. At the center is power and control. So that's the main issue. But what's sort of supporting the violence is all of the spokes within the wheel. So on the left, there are the topics, the main supports, the main spokes of that wheel. And within that wheel, if you can read it, are some of the examples. I'm just going to bop around the wheel and talk about some of the ones that I see most often. So I'll start at the top right, using intimidation. That's a common one because it is hard to document. When we're talking about potential legal consequences, it is difficult to get legal sanctions for it. And an example could be a very threatening look that in private is accompanied by physical violence, but in public can be merely a threat. And so the simple act of looking at someone threatening is not illegal and is difficult to explain the power and the fear behind that action without really divulging a lot of information. Emotional abuse is one that we're going to talk about quite a lot today. Putting people down, calling names, making people think they're crazy, playing mind games, humiliating that person, really sort of tearing down self-esteem and making people feel small generally. Isolation is also a very common way that people maintain control over their partners. It's done in a lot of ways. It's certainly done more easily when someone has financial control over someone or control over someone's transportation, or when they are just so vile and difficult that their partner simply cannot maintain friends. A lot of times what I hear from people is that my friends don't come over anymore because my partner was just such a pain. Using children as a way of controlling other people is also a very powerful manipulation tactic, either withdrawing or restricting visitation or sort of dragging them through legal processes. We could go on, and then I wouldn't be using all my other slides, so I'm going to move on a little bit. There are lots of adaptations of this power and control wheel, and a link to where you can find even more of those is provided in the slide and in the resources. There's an equality wheel, which talks about positive relationships as a way to talk about whether a relationship is positive or healthy or abusive and controlling. Abusive children wheel, economic power and control, abuse of animals, Christian power and control, using religion as a way to sort of enforce traditional gender norms is something I see quite a bit. There are lots of ways to talk about power and abuse and control, and there are lots of different situations that we have to know about so that we can properly relate to patients, because not everyone is sort of in the same situation as each other, obviously. The reason why it's called a power and control wheel is that it's not really actually about anger. What I hear a lot from people is that their abusive partner is very, very charming in public and can control their anger when it comes to their boss or the police or society in general. But their anger is specifically directed to just them. And what this tells you is that it's not just a general anger problem. And I think a lot of people, when they're grappling with the idea that their partner is potentially abusive and they're struggling with the sort of realization and aren't ready to label their relationship abusive yet, they might seek help for their partner's anger problem. And so what I would ask is this anger everywhere? Or is this anger just for you? And so that sort of tells you quite a bit about your answer. What undergirds the sort of abusive and controlling relationship is a belief by the abusive and controlling partner that they are the center of that relationship. They are more important, and they have a sense of ownership over the other person. And so anger towards that person is not the same as anger towards everyone else. And so if you are sort of helping someone tease through that line of thinking, asking them where the anger is directed towards can help. And then keeping in mind that other instances of power and control, once you start gathering a list of the ways that someone is controlling them or isolating them, you start to think this might be an abusive or controlling relationship. Manipulation tactics and psychological abuse and emotional abuse is more difficult to document, it's more difficult to describe, and it's certainly more difficult to prosecute. Physical violence can and often enters into play after a long period of emotional or psychological abuse. So a very typical pathway, and this isn't the pathway for every abusive relationship, is that it starts off very positively, romantically. Whirlwind-ish is often a trait of relationships that become abusive. Emotional and psychological abuse, creeps in as that person gains more control. So maybe one person moves to the other person's town, and that person who has maintained those social connections and power then has more room with which to exert power and control. Over the course of that, physical violence often follows, but it doesn't often have to stay, and here's why. Once a relationship has gone through sort of the progression into emotional and psychological abuse, if there is instances of physical abuse, they've achieved quite a lot of control and power over that other person. And so physical abuse, abusers know that that is often the abuse that gets you in trouble and gets you noticed. That physical abuse isn't as necessary anymore. They can lean back on isolation, intimidation, coercion and threats, economic control over transportation, money, and that is certainly less likely to gain the attention of all of us, the police, their friends, and the abused person's friends. It's important to keep in mind that psychological and emotional abuse can be just as harmful. It's been studied over and over again, and it doesn't come as a surprise to someone who is sort of steeped in the topic, but it might be a surprise to a lot of folks who aren't, that psychological and emotional abuse seems to lead to just as worse outcomes. The quote here, psychological IPV is typically less obvious than physical IPV, but research shows that it can have an equal or greater negative impact on the physical and psychological health of the recipient. And that should kind of floor you. That's sort of a ground-shaking realization that a lot of the abuse that I think probably goes less noticed is doing just as much damage as the physical abuse that sort of sticks in our minds, that we have images of that are terrifying and frightening. Research shows that it's even worse if psychological abuse is combined with physical and sexual abuse. So here, examples of physical and sexual abuse including pushing, grabbing, slapping, punching, strangulation, use of weapons, and sexual assault or abuse. Combined with some of the things we were talking about from the power and control wheel, financial control, restriction of social relationships, put downs, those combined are a pretty awful thing for someone to go through. And the poorest health outcomes come from people who are experiencing both. I put a star next to strangulation because that is something that folks in the anti-sexual violence and anti-domestic violence field consider sort of a real red flag. I mean, all of these are red flags, but strangulation is, linked to higher lethality of these relationships. So if you have someone who says that he choked me or she put her hands around my neck, that's something that you really have to sort of put a pin in and really follow up on, because those relationships, once they've gotten to that point, often are much more likely to lead to a fatality or a great bodily injury as well. The next 5 slides are going to be, it's pretty poor like PowerPoint etiquette, I have to admit, but it's going to be a very long list of some of the red flags. And here's why. Abuse shows up in lots of different ways. So the first part of this slide is going to be sort of things that are going on in an abusive relationship that you can ask about. And the reason why we need to have all these lists is because this is a lot easier to ask someone than the question, are you safe at home? And that's something that I used to do and still fall into as well. Leaving the question, are you safe at home, as the main interrogation into whether someone is actually safe at home. There are reasons why that question is okay. It's a soft question. It's a gentle question. It's not an accusatory question, so it's good in that way. But it doesn't actually get the information that we're seeking. Because I think when a lot of people hear, are you safe at home, they're not thinking about intimate partner violence. There was, and still is, sort of this, I'm not sure if it's a cultural thing or just a societal message that it used to be, certainly, that intimate partner violence and domestic violence was a private matter, and that it was something that was supposed to be handled at home. I think that's been largely and roundly rejected at this point. But we still maintain a lot of the thoughts and beliefs that we were raised with, even though intellectually, I know that intimate partner violence is a public health issue. I know that there are people out there that sort of immediately think, oh, that's private. That's a relationship thing. That's a something that they should deal with at home. And so I think when some people hear, "Are you safe at home?" they think, do I have running water? Is my neighborhood safe? They're thinking of physical safety and shelter rather than specifically emotional abuse and emotional harm. And so when you ask someone, are they safe at home? I'm not even sure they're answering the question the way that you anticipated. They're not sure, and I don't think everyone assumes that their romantic partner is the topic of that question. And so, safety from what is sort of the issue that we're at here. So when asking or trying to observe this list of things, what you're doing is you're observing hallmarks. And if you ask someone, are they taking money from you or refusing to give you money for expenses, that's a yes or no question. They might have a way to explain it. They might say, that's how we agreed to do it. That's the best for us. And then it's a lot less of a red flag. But if you ask someone, are they controlling who you see, where you go, and what you do, and they say yes, and they're not happy about it, then you have yourself a red flag. And you've really gotten a lot further in the conversation than when you said, are you safe at home? So you can read the list for yourself. I'm going to pick out some of the ones that I see pretty often. Taking money and refusing to give money for expenses is a large one. Controlling who you see is a big one too. A lot of times it's controlling, who you see because of what they will call jealousy, right? I am jealous of you when you see people who I think you might be attracted to. And the way I'm going to deal with that is that you don't get to see them anymore or anyone anymore because I don't trust them either. So that's kind of jumping pretty big from I have a jealousy problem to I get to tell you who to see. But that's one of the things that controlling and abusive people do. Blaming the victim for abuse and acting like it's not really happening happens a lot. And it's a very confusing situation for the person experiencing the abuse. And in fact, it can be a challenge to, even after going through this list of things and saying, wow, there's a lot of hallmarks of a controlling and abusive relationship here. That doesn't automatically mean that person's going to say, I see what you're saying. After a lot of time spent with someone that they care about and they might even still love very much, it's very difficult to sort of say, hey, this is an abusive relationship. I want to spend some time specifically on some of the red flags of emotional abuse because, as we said, it's a little bit harder to detect and to talk about. Jealousy, criticism of appearance, being punished by withholding attention or affection, name calling, making threats, not wanting you to work. That's a big one. I work with a lot of people that say, I would like a job, but they don't want me to get a job because money comes from having a job, and that means a little bit more power and independence. You also get a lot of social connection from working at a job. So that goes very much to isolation. So a lot of these red flags you can talk about and you can ask about, or you can surmise from some of your observations of patients, especially if their partner is with them often. So if you see someone who is answering on behalf of your patient and it doesn't seem like that's exactly what the patient wants, that's a red flag. And you sort of have to use your gut and your intuition to figure out, is this person just being helpful and trying to share the load? Or is this person making decisions on behalf of another person with their own self-interest in mind? A lot of this last list right here, this last one right here, your partner overloads you with compliments and gifts and then uses that to manipulate her. It's what some folks call love bombing. That brings to mind something I probably should have dedicated some more slides to. I think I have too many slides already. But what you'll often see in an abusive or controlling relationship is sort of what some folks refer to as a cycle of violence, meaning there is escalating tensions in the home. there is increasing anger and irritability, increasing threats, perhaps physical violence. Then there's something that's called a honeymoon phase, or an apology phase, where the abusive partner apologizes and perhaps perform some grand public gesture or grand romantic gestures as a way to make up for it. And then there's a period of relative peace before the tension builds again. Outburst, apology, honeymoon, calmness, that sort of up and down nature of that relationship. What people often do is, they will say, I'm a good partner because I bought you all those flowers, or I'm a good partner because I took you on this trip. How could you say that I'm an abusive person or that I'm a bad partner? It serves multiple goals, because often abusive and controlling partners want to appear to be very good people, because it makes it much more difficult for someone who, again, socially isolated, maybe not a lot of strong connections, when that person starts saying, oh, actually, they've been treating me very poorly. So, I hate to be, the biggest cynic in the world, but when you see very lavish and very public displays of affection that seem to be over the top, or even for the benefit of not just the object of that affection, consider that as maybe part of a cycle where someone is kind of on this up and down roller coaster relationship. That's a long list and a lot of red flags. And again, you don't have to know all 30 of those red flags in order to be a really good ally to someone who's going through this. One thing that I arguably should have started this whole presentation with is gender. I'm a male person in a field that gender is sort of part and parcel of these relationships, and part of the power dynamics between most of the relationships that at least we see at Beacon. So what often underpins, this idea that the abusive person gets to own and control the other is just gender ideas that maybe men should control women, and men should tell them what to do. I think at this point, we criticize that idea quite a lot. Some of us criticize that idea quite a lot. But it is, certainly not quite at relic status yet. There are certainly folks that believe that still to be the case. And when someone does believe that, it's more likely that they will sort of augment that into a very unhealthy relationship. That doesn't mean that men don't suffer from IPV. And so that's sort of the point of this slide, is that, I talk to men pretty often who are experiencing a lot of this same stuff. And in fact, 1 in 7 men have been the victim of severe physical violence by an intimate partner in their lifetime. And I think that's a larger number than I would have suspected, even having been in this work for quite a while. Another wrinkle that I do want to mention is that research shows that while men might be experiencing emotional abuse at similar rates as women, we report it far less. And I think the reasons for that, become pretty clear after thinking about it a little bit. One, if I can just speak on behalf of the 3 billion of us or whatever, we generally don't talk about our feelings as readily with other people. And two, we're sort of held back by this idea that masculinity is supposed to also be strong and tough, and how could we allow that to happen? There's also fewer resources, so I think a lot of times, the staff and the researchers and a lot of the folks that are in the anti-sexual violence movement, it makes sense. The large majority of them are women, and sometimes men want to talk to other men. So if you are a male healthcare provider, it might be a special calling for you to pay particular attention to other men. Not always the case, but sometimes when men give us a call, they really would rather talk to another guy. Now we're going to start connecting, my knowledge with your knowledge. Health outcomes for people experiencing IPV are pretty poor. For example, women who have experienced IPV suffer health effects even after the abuse is over. Common outcomes include chronic pain, perhaps due to neurophysiology changes after incomplete strangulation and head injuries, headaches and migraines, gastrointestinal symptoms, gynecological problems, PTSD and depression, and injuries from the physical abuse itself, often not reported as injuries as a result of domestic violence, right? You can imagine that if someone, will say, broke their arm or comes into the hospital with a broken arm as a result of physical abuse, that might not be the time where they decided they were ready to do something about their relationship. And in fact, they're at a particularly vulnerable time because their health is poor and they might be less physically able to take care of themselves. And so it makes some sense that they aren't ready to disclose and they will say that it's due to something else. So a lot of those injuries, you can't, go hunting for zebra when you see horse prints, but we do have to keep in mind that physical injuries often are the result of physical abuse and aren't reported as such. This is a sort of a different look. This is from a World Health Organization document. What I've talked about so far are sort of hallmarks of the relationship itself. But that's not exactly what is always on our agenda when we are treating patients for maybe a completely unrelated health issue. And so these are some signs that are a little bit more observable and don't depend on a person's willingness to disclose things about their personal relationship. So again, not a perfect checkbox. You're not saying A plus B equals C, but some things to look out for: symptoms of depression, anxiety, PTSD, suicidality, self-harm, alcohol and substance abuse, chronic pain that's unexplained medically, unexplained chronic gastrointestinal symptoms, unexplained genitourinary symptoms, adverse reproductive outcomes, unexplained reproductive symptoms, repeated vaginal bleeding and STIs, traumatic injuries with vague or implausible explanations, problems with the central nervous system, including headaches, cognitive problems, hearing loss, repeated health consultations with no clear diagnosis, and an intrusive partner in consultations. So these are things that you can observe that maybe clues you in to think maybe there's a relationship issue that's going on here. So here's another poll everywhere question. What are the most common red flags that you are seeing during patient visits? Now that I've listed all of them for you, not all of them, a large number of them, what's sort of popping out in your head as far as things that you've been seeing?
All right. And again, this is entirely anonymous, so we're not going to see who you are as you're submitting these. This isn't even tied to Zoom, and we really appreciated all the responses on the last one.
Yeah, if someone says physical abuse, that's certainly a red flag. Seeing a lot of partners speaking for patient, which is a tricky one because sometimes that's what they want or is more normal culturally, but is often a red flag. I'm glad someone said love bombing. I think that's one, red flag that we just see it as a flag sometimes. Not allowing partner to work outside of the home without any sort of real medical reason. That happens all the time. Financial control is also really difficult because there isn't always an immediate answer to what do you do about that. Sometimes extricating yourself out of an abusive and controlling relationship takes a whole lot of time, and we're going to get there in a moment or two. Yeah, what I find interesting here is that the most common red flags aren't the most obvious red flags. So what I'm not seeing a lot of is, injuries that are suspicious. Some of the immediately obvious stuff isn't the most common stuff. So I think a lot of you probably are thinking this way, but we have to start looking at not the physical obvious stuff. Intimidation, Influencing or questioning patients' decisions. That's another one. Nervousness, which I think is interesting. I think, if I'm in an abusive or controlling relationship and healthcare is really one of the access points, one of the few times maybe that the controlled person is talking to another person one-on-one with some privacy. They might be nervous, one, because sometimes hospitals and healthcare providers make people nervous. But it might be because they're really thinking about making a big change in their life by disclosing. So I really like nervousness as a red flag to keep in mind. Now that we've talked about observable things, we have to talk about mandatory reporting. And this could be its own, I think, presentation. But in my corner of the healthcare world, when I'm working with adults, and that's primarily who I work with, intimate partner violence between two adults doesn't necessarily require a report to social services, whether that's APS or CPS. Unless, and I think this is where it starts to tie into some of y'all's work, unless the person being abused is dependent on the care of another. So if there is a caretaker and a person dependent on them, and the caretaker is abusing that other adult, that's a mandatory report to Adult Protective Services. And what that means, in North Carolina, everyone is a mandated reporter. What that means is that we should be calling the County Department of Social Services and reporting. The process is relatively simple. There are legal protections for people who, in good faith, make a report. And there are some protections for keeping who made the report anonymous. However, I know that I've made reports and that people immediately figured out that it was me. And so there are really difficult and complicated ethical questions that we have to ask ourselves when we're faced with that situation. What comes up more often for me is when children are exposed to intimate partner violence. In North Carolina, that should be a mandatory report to Child Protective Services. And here's why. Exposure to IPV in children is really, really damaging and harmful. You can look up yourself the research behind some of the poor outcomes for children who grow up in homes with lots of intimate partner violence. Now, I'm going to start speeding up here a little bit because we have to talk about cancer patients. So luckily, here we are. What percentage of cancer patients do you think report recent IPV victimization?
All right, we encourage you to take about another 15 seconds or so. Go ahead and again, all anonymous, take your best guess, and we'll find out the answer together in just a moment. Well, Joe, it's all over the map. How are they doing?
It's a tough question. And measuring this stuff is always difficult.
Yeah.
But currently the best research guess is about 24.8%, about 25%. This is higher than the general incidence rates. So, general incidence rates of current IPV by a current partner usually float around 15% or even a little bit lower. And so 25% is an increase. And so we have to ask ourselves sort of why. And I think there are sort of two causal directions. I'm not an expert in this. You can confirm with me, but in my thinking, there's probably two causal directions. One, IPV as a risk factor for cancer, which I didn't really know about that. But higher rates of cervical cancer among women who have been abused in their lifetime, up to 10 times higher. And that seems pretty wild. A study of 101 women with breast, endometrial, or ovarian cancer found that having experienced abuse in the past was common, 48.5%, which is also a much higher incidence level than general population. Additionally, advanced stage of their illness at diagnosis correlated with extent of history of IPV, likely because part of this isolation and financial control over transportation means accessing healthcare less often. How would having a cancer diagnosis contribute to the potential for IPV? So in the other direction, my thinking of it was you have increased dependence, right? So if I have a patient that currently is undergoing cancer treatment, they might be more financially, physically, emotionally dependent on their partner. That does not make their partner into an abusive person, but once that partner has more power and more control, we know that that's sort of the requirement for when someone actually uses that power and control in order to be abusive and controlling. I think maybe some withdrawal from social connections. So if someone is going through cancer treatment, depending on what stage they're at, they may have less energy and less time to stay connected to church families, to work, to friends. And so more isolation, again, equals more dependence and more power and control by the other person. There's some commonalities, I think, between people experiencing IPV and the experience of a cancer patient. Not that they are similar topics, but there are similar challenges, I think. Some of the risk factors for IPV being history of being psychologically or physically abused, poverty, weak community sanctions against IPV, economic stress, marital conflicts, young age, substance abuse, traditional gender norms. Not all of that applies to cancer patients, but I think some do. Cancer probably causes quite a lot of economic stress. It can really strain your otherwise healthy or fine relationships. I think you probably observe quite a lot of familial strain where maybe it wasn't before. People experiencing a whole lot more stress can turn to other unhealthy ways of dealing with that, including substance abuse or risky behaviors. So there are some, and these aren't direct cause and effects things, but I do have a feeling that if someone is going through very difficult, very dramatic, traumatic health issues, that makes them quite a bit more vulnerable to someone who would use that power and control to abuse that person. Particularly, if we're going to be really on topic, I think increased reliance on partners for support. So in my knowledge of knowing people that have gone through cancer treatments, they go to the hospital a lot. There's a lot of things to do. And often, if we are considering people living in rural areas, or if we are considering families that have one car, they're relying on someone for transportation, and that person controls their access to healthcare. Usually, that's fine. But someone in an abusive relationship, they have some new thing to hang over their heads to exert control. Expensive treatment, and so if you are financially dependent on a breadwinning partner and they are abusive, you're certainly going to have a harder time leaving when you need this treatment. Social isolation due to stress and decreased energy, we covered that. And the repeated trips and travel is quite a burden as well. So what do we do? And I think that's a good place to start wrapping up. What I want to keep in mind is that there aren't like single superheroes in this process. You're certainly not alone, and so take comfort in that. You're not alone in providing support and resources to this person. But quickly, be non-judgmental, and what that means is not hearing about something and sort of exclaiming like, "Oh gosh, like why are you with that person?" Like, why don't you just leave? Those sorts of things. We want to, as we typically do when treating people in a healthcare setting, just listen to the facts and respond sort of calmly and respectfully. What's really important for someone who is in a controlling relationship is that you allow them to be the captain of their ship. If we were to try to come up with the solution or the next step for them on our own, we're grasping at straws. We're doing math with a lot of variables that we haven't solved. The patient themselves know what the safest way to leave is and when it's beneficial for them, when it's possible for them, and how to do it. It might take a long time. So there are some people that I work with that they come up with a plan for leaving. and it takes several months to sort of get all their stuff together. Providing information in a way that is safe to the patient. So understanding that controlling and abusive people also tend to monitor phones or monitor emails or log into people's MyChart and read medical charts and things like that. So talking with the patient about how do we continue to communicate in a way that is safe. There is a very large structure of domestic violence agencies nationwide and in North Carolina. Essentially, we have federal funds and agencies that provide training and technical support and money to local domestic violence agencies that exist in almost every county in North Carolina. The North Carolina Coalition Against Domestic Violence, which I link in the resources, will tell you which agency in each county is the best place for a domestic violence victim to go. Because they have state funding and they are federally funded as well, there's a certain baseline number of services that they provide. And they are listed as such. They are 24-hour hotlines, access to domestic violence shelters, support groups, and court accompaniment, so help with any sort of court dates. So what might be the most effective way to help someone is to respect that person's ability to choose when they get the help and how, and then direct them to their local agency, which they can access when they know that it's safe and actually has resources to help them out. Some of the pitfalls that we can fall into is trying to take over. A lot of times we're trained to sort of be active and proactive, and that's a really good trait to have, but not right here. We should be a little bit more responsive. Any sort of decision-making that we take away from the patient sort of replicates the dynamic that they're experiencing at home. And they will trust you very much if you allow them to make decisions for themselves. I'm skipping some of the charts that you can go back into because we are running out of time. I told everyone that we certainly weren't going to go under time, that we were maybe going to be over time. I wanted to talk about some other action steps that can be taken after meeting with a patient. So we could do a whole half hour on protection orders, domestic violence protection orders, but I want you to know that you can get a protection order that requires a person who is abusing you or hurting you to leave the home even if they own it. So I think a lot of people are surprised when they talk to me about, she owns the house and she's been abusing me. He could get a protection order and the sheriffs would ask her to leave. So the idea that they are trapped within their own home might not necessarily be true. It's not an easy process, and there are some ways to do this online that I've linked here, and there are legal aid offices across the state that help with that. And again, going to a local domestic violence agency will give you access to that help as well. The list of domestic violence agencies already mentioned, and then safety planning. Safety planning is basically trying to anticipate a future emergency and deciding what your action steps are going to be before that happens. So very briefly, an action plan could be, if I need to leave, I'm going to go to this friend's house. And I'm going to carry my wallet, and I'm going to make sure that my birth certificate's in this one spot so that I can just grab all my stuff and go. And then talking to that friend ahead of time and saying, hey, could I stay at your place for a little bit? That's a very simple safety plan, which is helpful to have in your back pocket when things get really sideways, because it's harder to make decisions in those sort of split-second situations. The National Domestic Violence Hotline has a safety planning tool that makes this a pretty easy thing to do. So the take-home points, if you are recognizing that someone might be dealing with one of these situations, bring Beacon in if you're part of the UNC Health system. Educate primary teams so that some of those red flags don't go unnoticed. Grab information about your local domestic violence agency to have on hand, and advocate for increased awareness and comfort in exploring these issues with patients. If you do those things, you're you're a greatly improved healthcare provider to someone who might not know what the next steps are. So I invite you to check out some of the research studies I referenced, and a lot of these other resources have a lot of information too. It's a huge topic, and 1 hour certainly isn't enough to cover everything, but I hope it's been helpful to you so far.
Joe, this has been great. Thank you so much.
Great.
Let me go ahead. I'm just going to advance the slides here so that we've got that Q&A slide. So this is your chance I mentioned at the beginning. If you jotted down those questions, or if you've got questions for Joe now, please go ahead and share those in the poll everywhere, and we'll look at as many of those as we have time for.
Sure.
I've got a little list myself, but I'll try not to monopolize your time. So you mentioned for UNC Health folks, Beacon, are there sibling organizations that you're aware of for Duke or Wake Forest or other healthcare entities within North Carolina?
I know at Duke they have a women's center that's associated with the university. I'm not sure about the hospital.
Okay.
I think Beacon is actually pretty unique, though I wouldn't be surprised if there's something out there that I don't know.
Gotcha. All right, and we do have one question that came in. There we go. Since most Epic Notes are accessible, viewable to patients through MyChart, do Beacon staff use the Do Not Share with Patient button when writing these notes?
Yes,
Great,
every time.
practical question.
Yeah, a very practical question. We were assured by the Epic folks that it automatically happens, but we click the Do Not Share button every time. And then at the top of each note, we have a smart phrase that explains, hey, for this note and future notes about this issue, please block from patient.
Okay, thank you. I know you mentioned, let me find, are you safe at home? And that sort of standard question. What are some succinct alternatives to that? I know you talked about that a little bit earlier, but maybe reinforce that.
Yeah.
What are those other questions that might open things up a little bit more for the conversation?
It's much more complicated if their domestic partner is there with them. Then you've got a whole other challenge. And I've worked with nurses to sort of come up with small ruses to get them out of the room.
Because that was going to be my next question is when do you decide, okay, I really need to speak to this person without the partner there, and how do you go about that?
That's right. So nurses are awesome. I usually figure out who's the nurse working with that patient and see if there's any patterns to that partner's behavior. Do they leave for lunch at a certain time? Are they here during the day and they work at night? Do they work at night and are they here during the day? Is there any task we can ask them to do to allow me to even just place a phone call to their bedside phone and ask something like, is there someone hurting you? Is there someone in your home that's hurting you? Does someone make you feel bad? Still very general and not super invasive, but a little bit more on topic.
Got it. So, okay. And we have just another minute or so. If anyone else has a question for Joe, let us know. Let's see. I was just looking to see. This is great. Awesome. What I'm going to do is I'm going to jump ahead and just go over a couple of slides I need to cover, and then we'll stop back once more to see if anyone shared a question. Right. So we want to thank the people of North Carolina for their generous support of the University Cancer Research Fund, and which we call UCRF, and the UNC Lineberger Comprehensive Cancer Center, which makes all of this possible. So thank you. We want to thank our team, Benny Obore and John Powell, Oliver Marth, Andrew Dodson, Nadja Brown, Patrick Muscarella. They all do a lot of work behind the scenes to make this all happen. And